what we noticed in this endeavor is that there are certain patients, there's a small portion of patients, but that they, if not quickly, symptom management not quickly recognized, then they would exacerbate quickly and then they'd end up in the hospital. And it was just a repeat cycle. And to break that cycle and also improve the quality of life for the patient, we began that journey again about 3 years ago. And we actually call ours, it's palliative care services, but we focus really on advanced illness management. This team is looking at these people that are advanced in their illness trajectory, such as heart failure. We know that they're not going to be cured, but we do understand that we can manage symptoms if we have early recognition of it.
Well, the Advanced Illness Program at the VNA of the Rockford area, what we're looking at and seeing with patients is that there are many more complexities when they're being discharged from the hospital or being sent home from the hospitals or to other skilled care facilities. These patients have multiple problems. There's multiple comorbidities. So these patients need to have more oversight, per se. What we also want to do is we want to engage the patients. That's one of the biggest things, is engagement of them, having them be actively participating within their care and within their care continuum. What we're looking for is to eventually get them to the point of self-management, where they can control their own symptoms, they can control their disease state, and know what actions to take through early recognition and early intervention to keep them from being seen in the emergency room or for readmissions. Part of what we do with that is with the education process. We work with the patients with the teach-back method so that we're discussing with them what their care is and what they can do for it, but then have them teach us back what they've learned. Another key component that we have introduced here with the VNA of the Rockford area is use of telehealth monitoring. We have expanded it not just from the patients that are VNA patients with intermittent care, but also to the patients that may not be eligible for Medicare coverage with home care. These are patients that are discharged from the hospital, but are still being seen by a cardiologist from the Heart and Vascular Organization, Heart and Vascular Group. We will put a telehealth monitor in their home to help manage them. Again, what we're looking at here is the early recognition and early intervention. So these patients are going home, they're being set up with the monitors, and we're getting daily vital signs on them. We're watching for slight trends, whether it be weight gain or blood pressure, heart rate, pulse oximetry. But one of the key components is with the weight gain. We have parameters set of 3 pounds in a day to 5 pounds in a week. Along with our advanced illness management, what else we look at is health literacy of the patient. What is it that they know? What is their education base? What is their knowledge base for their disease state? And health literacy, you sound literacy, you think of the ability to read. And some people will admit or say that they're reading, but really they're not. They aren't able to. So some of the ways to get around that is to have them read to you what their pill bottle says. And if they struggle with that, then you know that you have an issue. Or you can ask a question of, how well do you read, or how well do you have you read your discharge instructions from your physician or from the pharmacy? So those are kind of keys that you can get for the reading part. But another big cue or a big issue is quantitative literacy. Do they know how to add and subtract? Do they know that, okay, you have given them 2 milligram pills and now the dose has changed to 3 milligrams. Do they understand that what they need to do is to cut one of those tablets in half? So there's a lot of back and forth and a lot of questions that you do whenever you're interviewing the patient to find out just where they're at with their health literacy. And then again, it goes back to teach back. You give them the opportunity to tell you what they've learned or tell you what they know, and then give them the opportunity and then educate them. And then again, like I say, have them, give the information back to you. Some patients are very, very cued into what it is that we're looking for and what are the answers that we're wanting. And one example of that was a patient who was weighing themselves, and it was every day their weight was right at the same time or same point, maybe 1 or 2 pounds off, up or down. So the nurse cued in on this, maybe things aren't quite right. So ask them, show me how you weigh. Show me where you weigh. And the patient started to walk back to the bathroom, and sure enough, they didn't have a scale. But they knew what the answer was that we were looking for, so that we weren't going to go any further with it. And you know, that's just one of the examples. And it's just like, all it was is getting a scale for them, putting it in their house, and lo and behold, they were good. So those are some of the things with health literacy. As I was mentioning before, with quantitative, with our medications, one of the big things that we've worked at with Rockford Memorial is within the pharmacy department, and having them do medication reconciliation and start that in the hospital and start that through their hospital stay into discharge, and then once they're home as well through the transition of care. Transition of care is a phrase that we use to not just go from hospital to home, but there's also transition from home to doctor's office, or from hospital to visiting nurses association, or hospital to doctor's office. There's so many different transitions that play a key role in keeping these people out of the hospital, that everybody needs to be on par with what's going on. Everybody needs to know what's going on. So communication is a key factor within the transitions of care. And making sure, like I say, the patients are educated, the families are educated, and it can help with their outcomes. Initially, whenever we first implemented the program in 2012, readmission rates for the hospital were about 25%. We started the program where the patients that were being discharged but didn't necessarily qualify for Visiting Nurses Association care, we entered some of those patients, or we entered most all those patients into the program. Readmission rates in 1 year's time went from 25% to 17%. Currently, year to date, we're at 15%. Now that's overall all the CHF patients that were discharged from the hospital. Not everybody that was discharged from the hospital qualified for the program. The program was implemented for patients that did have a cardiologist on staff at Rockford Memorial Hospital. The patients that were entered into the program, within the first year, all-cause readmission rate was 9%. Patients that were readmitted related to CHF symptoms and CHF exacerbations was 5%. Currently, year to date, we're looking at an 8% readmission overall and a 4% readmission rate for those that are related to CHF exacerbations. If somebody were to ask me to replicate what we were doing, you would need the buy-in from the physician staff in the hospital, along with the nursing staff on the units. We have a transition care coordinator or coach that's in the hospital that is also brought in to assess these patients that are diagnosed with CHF. You have the discharge planners. You have the staff of the visiting nurses that are watching with the telehealth program, who do the setups of the monitors, the person who puts the patients into the system. You have a person who is monitoring the vital signs on a daily basis. And then, like I say, you have the collaboration of the physician group that you're reporting to. So that could be any number of the cardiologists or the nurse practitioners that you're giving the data to, who then act upon it. And also you have to have the patients and the families. They're vital as well, because they are going to be the ones who are going to take action at home. They're going to be the ones that are recognizing things in the long run. Really,
the most effective interventions are ones that take part of an interdisciplinary team. There's a lot of data to show that education alone usually isn't enough, but providing different help from different parts of the interdisciplinary team really help make programs successful. I set up a program at the hospital in conjunction with the interdisciplinary team to kind of improve medication adherence and to keep high-risk patients out of the hospital. And the students help me with that, as well as get some good learning experiences along the way. Patients usually, if they can provide the information themselves, they are usually correct. Sometimes I will test patients, ask them frequencies of medicines that are very standard, and then I'll ask them, other medicines on their list. And a lot of times, if patients are tested and they can say that they use a medicine once a day and it's the standard dose is once a day, and then I say another medicine name and they don't know about it, it seems like the majority of time that's real good information. When I back that up, when I try and call their pharmacy or their primary care physician, it's not a medicine they're on, or it's something that had been stopped a couple of years. And so taking the little snippets of information that the patients get you or give you I mean, believe them. I mean, if the patient is believable in other areas, believe their medicine list when they tell it to you. But always verify too.
We are working towards controlling the symptom aspects of advanced illness and managing all of the components that go with that. The hope is that as the patients transition across the continuum of care and they reach the further stages of end of life, that they will eventually transition to under the services of hospice so that we can continue to control their symptoms and provide them the maximum quality of life possible. Through that continuum of care is the palliative care component, in which there is a huge emphasis on symptom management, disease management, quality of care, and reducing their need to return to the hospital. A huge focus is talking to the physician about the benefit of their services versus the burden to the patient. How will that impact your patient? Is your patient fully educated on the fact that they can refuse that service? Will that treatment potentially make them feel worse than they currently feel at this stage in the game? I think pain management is very difficult because it can be very subjective, and we need to remove that sort of umbrella or that label of dependency and the fear of dependency. When you're looking at the end stages or a chronic illness management process that could mean a couple of years, is dependency truly an issue anymore? And to keep in mind that there is no ceiling to the amount of medication that a patient can have, but that the comfort level that they are experiencing can significantly impact their quality of life and can also negatively impact their other comorbidities as well, if not controlled properly. What I would love to see is that the government recognize palliative care as a necessity, and that we begin to, or that we continue to find innovative ways to bring palliative care to patients while allowing there to be reimbursement for organizations. There is a significant lack of reimbursement opportunity under palliative care, which many times places an agency in grave jeopardy if they are continuing to provide the palliative care service to the patient at no cost. There has to be some type of compensation in order to continue these programs and continue to grow them and create the education and awareness that's needed out there.